Hi everybody, this is Dr. A. So we're going to look at the endocrine system for clinical chemistry, and so this is a pretty long lesson, so if you feel like you need to pause it, that's totally fine. Alright, let's start with, well, endocrinology is the study of the endocrine system, and the endocrine system is made up of all the glands that produce hormones. And hormones coordinate a lot of specific responses in the body, and they communicate within and among local and distant cells and with the nervous system. I like to think of the endocrine system kind of like a Wi-Fi system. So just like with Wi-Fi, you have a tower that's or a modem or something that's emitting the signals or cell data. You could go cell or Wi-Fi, whichever. There's something emitting signals and stuff that you're using and sending information back and forth, and you're picking it up with, a device it can. So it's sent and it's picked up at a distant location. And the nervous system would be more like a wired system of internet lines or phone wires or things like that. And so those signals, those endocrine system signals, which are hormones, are received by glands, and then they promote the synthesis of a protein, the release of a different hormone. There's just an effect that happens, and that's what we're going to be looking at in this entire lesson. So as a quick recap, the organs, the glands, if you will, of the endocrine system are the main ones are the hypothalamus and the pituitary. There's also the pineal gland that's not portrayed here. You have your thyroid and the parathyroid glands. You have your adrenal glands that sit on top of the kidneys, and if you will, the kidneys are also kind of an endocrine gland because they can produce hormones such as renin and erythropoietin. And then, of course, you have the pancreas, but it's not, the majority of the pancreas is actually for digestion, but the islets of Langerhans, which is only about 2% of the pancreas, is the endocrine portion of the pancreas. And then we have our ovaries and testes, so the reproductive organs there. So let's start with control and command. So hormones are released in patterns, and depending on the hormone, you're going to have different patterns. So the types of patterns you can see in the endocrine system are, for example, circadian. So a circadian pattern is a 24-hour pattern. Cortisol, if you will, follows a circadian pattern because it is increased in the morning, and then it decreases over the day, and it gets lowest right before bed, and then you'll see then it starts rebuilding at night, and so it has this 24-hour pattern that it goes by. Diurnal patterns are affected by daylight, so they kick in the morning and they especially can kick in if you're exposed to sunlight when you first get up. And so if you need to wake yourself really good, one of the things you can do is just simply go outside and get some sunlight on your face and on your body, and that really wakes somebody up. Pulsatile patterns are going to be hormones that are secreted just kind of in a pulse fashion, so just a little bit throughout the day, pretty constant levels that are secreted. So they're secreted in pulses. A cyclic one would follow cycles, and cycles can be days to months or whatever. So probably the best one to think of in cyclical would be the female cycle hormones, which is a monthly cycle. Okay, and then some just follow a pattern of trying to maintain a target level of a certain substance. Whether that substance, for example, would be glucose, and you have insulin and glucagon working together to maintain glucose at a certain target level, or you have a certain target level of thyroid hormones, and so those are different patterns that you can see in the endocrine system. There are also feedback loops, and we'll go into more details, which are part of the control and command of the endocrine system. There's positive and negative feedback loops. The majority of the control systems in your endocrine system are going to be via negative feedback. And negative feedback, as a reminder, is a feedback loop that lessens the change away from normal. And so this is whether this change has been an increase or a decrease. It just brings it back to where the set point is supposed to be. And so the best illustration of a negative feedback loop is a thermostat, with a set temperature for the room, and whether the temperature drops in the winter and then the heater kicks in to bring the temperature of the house back up, or the temperature rises in the summer and the AC kicks on to bring the temperature back down to the set point. Either way, it lessens the change away from the set point, so they're both negative feedback loops. Positive feedback loop, the change, it increases the change away from normal. The clotting system, activation of the clotting system is an example of a feedback loop, a positive feedback loop. Okay. Another part of the control and command of the endocrine system is the presence of receptors to bind the hormone and then carry out the effects. This is quite important, especially for all the peptide hormones, which is the majority of the hormones, which are protein. They all have to have a receptor to bind on. And if there's problems with the receptors, then you can get things such as a resistance to that hormone. So examples of that would be insulin and insulin resistance, and leptin and leptin resistance, for example. For example, insulin, we've discussed already in the pancreas lecture, but for insulin, the insulin receptor on the surface of a cell, when insulin docks on it, then the effect is going to be for the cell to put a glucose transporter port up into the surface of the cell membrane so that glucose can enter the cell. If there is a problem with the binding of the insulin and the receptor has lost its sensitivity to insulin, then the glucose transporters aren't going to be put into the cell surface. Generally, circulating enzymes degrade hormones. We want them to carry out their effective signal, but we don't want them to just stay there forever. And so once they've done their job, they're degraded. Hydrophobic hormones or lipid-soluble hormones, they come from the adrenal cortex. I'm going to look at those. They are in the minority, and they kind of have their own particular thing we're going to look at. And all of these, the endocrine system works with the nervous system to regulate responses to internal and external stimuli. So they're all part of this homeostatic control mechanisms to keep your body in balance. So again, this is for an example of feedback loops with the endocrine system, and so with the different levels. So usually the beginning of it is going to be at the hypothalamus. So there's a input signal of some sort, whether from the central nervous system or from detecting of the hormone levels that it's monitoring. That input could be a negative or positive. So that means it could be there's not enough of something or there's too much of something. Okay, and the hypothalamus is going to react depending on what the signal is. And usually if there's not enough of something, of a hormone, and we need more of it, then it would releasing hormones. But if it's too much, there's some release inhibiting hormones and factors. So it can go either way depending on what the signal is, right? And these can go, these cross over and affect the anterior pituitary, and it tells us either if it's a releasing hormone, it will tell it to release that specific hormone that is going to be needed, or if it's an inhibiting hormone, then it's going to tell it to not release that specific hormone. And the anterior pituitary then makes what we call the tropic hormones in response to the signal from the hypothalamus. And we're going to look at the variety of the tropic hormones, but the tropic hormones have the effect of traveling through the bloodstream, leaving the anterior pituitary, and then hitting the target organ or target gland, and then that target organ or target gland and will release hormones in response to that, and those hormones will go and have their physiologic effect. The release of those hormones then serves as a feedback loop both to the pituitary and to the hypothalamus to say, hey, yes, we got the signal, we did the job, the levels are back up, okay? And so this is a very good illustration again of a negative feedback loop. So negative feedback loops lessens the change away from normal. So whether it's increasing or decreasing a hormone level, it is the most common feedback loop in the body. Almost every hormone is controlled by a negative feedback loop system. And you get cycles of secretion that maintain the physiological and homeostatic control. So again, depending on the hormone, these cycles can range from hours to months in duration. And so some of them have monthly patterns, some of them have daily patterns, some of them have hourly patterns. And so again, there's going to be a variety. We're going to look more specifically into each system. An example of it's pretty typical negative feedback loop is going to be thyroid hormone production, and we're going to look at that here in just a second. And then again, a positive feedback loop increases the change away from normal. One of the hormonal ones that follows the positive feedback would be oxytocin that's released during child labor. And so basically the labor and the contractions increase steadily to increase. It gets stronger and stronger, and culminating obviously into the delivery of the baby. But it keeps going. It's the idea of that it's like turning on a faucet. It just keeps getting more and more and more and more until the effect is finally achieved. So using thyroid as an illustration of a negative feedback loop, so the hypothalamus is going to produce TRH, which is thyrotropin releasing hormone, which is going to cross through the bloodstream to the anterior pituitary, which is going to respond to that by releasing TSH. So this is a signal to make more of, which will release. TSH is going to be released through the bloodstream and travel through the bloodstream over to the thyroid and tell the thyroid, please release thyroid hormones, which is T3 and T4. And then the presence of those thyroid hormones is going to give a negative feedback saying, okay, the levels are up. Now we're good. We don't need any more TSH. So that's the negative feedback saying, hey, we don't need any more TSH and we don't need any more TRH because the levels are up. And then if it senses a decrease in T3 and T4, then the whole thing starts over again. So let's go over the types of hormones. The majority of your hormones are going to be these peptides, polypeptides, protein type hormones. Example are growth hormone, insulin, leptin, parathyroid hormone, prolactin, ACTH, which is adrenocorticotropic hormone, antidiuretic hormone, calcitonin, all your endorphins, glucagon, etc. There's quite a few. There's just a big old laundry list of these guys. They can circulate freely in blood because they're proteins, they're peptides. Peptides are water soluble, and their half-life is usually a few minutes. Then there are also some that are glycoproteins, which are proteins with a sugar attached to them. Those are FSH, LH, and TSH. Their half-life is also a few minutes. And they also do not need to bind to other proteins in the blood because they have a protein component which makes them water soluble, so they can just float around in the blood, no problem. Then your amines are T3 and T4, and epinephrine and norepinephrine. So T3 and T4 have a half-life of a few days, whereas epinephrine and norepinephrine have a half-life of a few minutes. Now, I do want to note here that epinephrine and norepinephrine can also function as neurotransmitters, but here we're discussing them as hormones. All of these amines are made from tyrosine, that's their precursors, an amino acid, so it's needed for T3, T4, and for epinephrine and norepinephrine. Then you have your steroids. So your steroids are kind of a category on their own. So far all of these have kind of like a protein component or amino acid component. Steroids are made from cholesterol. Cholesterol is a fat, so they must bind to protein. They have to be transported by protein through the blood because, fat is not water soluble and is lipid soluble. Examples of your steroid hormones are going to be estrogen, glucocorticoids, your mineralocorticoids, your progestins, etc. And we're going to go over some of the main differences between these. And then you also have arachidonic acid derivatives, and those are your eicosanoids, which drive inflammation, and they're made from polyunsaturated fatty acids. So these are also fat-based. And so, incidentally, I bought a fit index scale that tracks your fat percentage and your water percentage and your weight, etc., with biometric impedance readings. And I found this really interesting, that when inflammation increases in my body, I was thinking I was getting like water weight, and actually it's not. It doesn't. My water doesn't increase. It's my fat that increases, and it's not that I'm gaining a pound of fat. It's just that all the inflammatory molecules are eicosanoids or arachidonic acid derivatives, so they're fats, and so it's registering those, and so it's saying, oh, overnight you gained a whole pound of fat, which is not likely. It just means I have inflammation. And then if the inflammation clears, overnight I'll lose a pound of fat, which is not true, a true pound of adipose fat. It's just inflammation. So that's a sidebar. This is an activity in Nearpod for my class, so we're going to move on. Okay, so these protein hormones, so the amines, proteins, peptides, polypeptides are the majority of hormones. They're usually synthesized and then stored in secretory granules and then released as needed. They're all water soluble because they're made from proteins, therefore they don't require carrier proteins. And they will all have to attach to cell membrane receptors. So your cell membrane receptors are kind of dancing, zipping around on the surface of the cell membrane, looking for, available there for its peptide or polypeptide to bind on. Once its peptide binds on its receptor, then what happens is there's a change. So this happens on the outside of the cell membrane. On the inside of the cell membrane, then it activates a messenger, often something like cyclic AMP, and then that triggers a cascade of reactions that come from that receptor being activated. And the effect could be the synthesis of a protein, the activation of an enzyme, or whatever signal that's supposed to happen from that receptor being activated. Okay, but the point of it, again, is that the hormone stays on the outside of the cell. It never actually comes into the cell. Now, the steroid hormones are a completely different animal here. First, they're produced as needed. So there's no storage of them. Because they're made from cholesterol, they're lipid soluble, and therefore they must bind to a carrier or transport protein to, go about in the blood. And these guys can passively diffuse into the cell. Why is that? Because the cell membrane, if you remember, is a bilayer of phospholipids, so it's lipid based, and so lipid can dissolve in lipid, and so these little guys can just basically phase through the cell membrane without needing a receptor of any kind of sort. Now, they do have a receptor. It's just this receptor is usually a nuclear receptor. So, and they will go in and form the receptor ligand complex. It's just not on the cell surface, it's inside the cell. So steroid hormones usually bind inside the cell to a nuclear membrane receptor. And then what that does is it produces an activated hormone receptor complex. And then that triggers usually DNA transcription or DNA replication, and so it can turn specific genes on or off and therefore increase the production of proteins. So the big difference between steroid hormones and peptide hormones is these fat-soluble steroid hormones go and activate DNA, or like I said, turn genes on or off. And then your little amine hormones, tyrosine is the common precursor to all of these. Your catecholamines are water soluble, but thyroxine is lipid soluble. And so your catecholamines are epinephrine and norepinephrine. So these guys are water soluble. Thyroxine is your part of your thyroid hormones. That one is lipid soluble. Therefore, those would require transport proteins. So thyroxine is carried on transthyretin. So if you remember, transthyretin transports thyroxine and retinol. Retinol is vitamin A, also fat soluble. Okay. These activate a secondary messenger system in the cell, and they are all regulated by negative feedback. All right, quick little question. Which hormone does not need a cell membrane receptor? So if you look at all of those, I will give you one clue. If you're trying to pick out which one it is, it would be one that is not protein-based. There you go, because all your protein-based ones have to activate a cell membrane receptor. Okay, so how are these hormones measured? We're not going to get into all the specific techniques. You just have to know that the majority of the way these hormones are going to be measured are going to be a form of immunoassay, whether it's an ELISA, EMIT, or an FPIA. Could also be a radioimmunoassay. They can also be measured by high-performance liquid chromatography or gas chromatography mass spectrometry. And so if it's on a large analyzer, it's usually going to be an immunoassay of some sort. There are some hormones that are done pretty commonly in the clinical lab, in your hospitals and doctors' offices, and those would be more like your thyroid hormones. And then there's a lot of them that would have to be sent to reference labs, and these are going to be by HPLC or GCMS, but also potentially by immunoassay, like some of your reproductive hormones, etc., cortisol. All of those tend to be sent out. So let's look at disease processes again in a broad way. There are disorders and diseases of the endocrine system usually arise from tumors, inflammatory processes, or genetic mutations. And because in the endocrine system, you've seen even already with the feedback loops, there are quite multiple components to the cascade. Then whenever there's multiple components to anything, things can go wrong at any point in the cascade. So if the disease is a primary disease, it means that it's the target organ or the gland that's diseased. So in our thyroid example, if it was primary, the thyroid gland is what would be affected, is where the disease would be in the thyroid gland, and this you would have primary disease there. If it's secondary, it's usually there's a damage or defect or something's going on with the hypothalamus or the pituitary, so it's central, so it's at the level here of, from within the brain. And if it's tertiary, it is still hypothalamus or pituitary, but it's because of a tumor of some sort. And then you can also have ectopic disease, if a patient has a hormone secreting tumor. So for example, and this would be something outside of the endocrine system. So for example, there are some lung tumors that can secrete ACTH. And so adrenocorticotropic hormone is usually not secreted in the lungs, it's secreted in the pituitary. And so you have a lung tumor that's secreting a pituitary hormone. So that would be an example of ectopic disease. All right, so we're going to go into a little bit more specifics here. I'm going to start introducing this HPA axis and the idea of axis, and then we're going to dive into specifics. The Hypothalamic-pituitary-Adrenal Axis, also known as HPA axis, coordinates actions of the neuroendocrine system, so interfaces nervous system and endocrine system. And its interactions control your reactions to stress. So your HPA axis is your stress response. It can also regulate digestion, immune system, mood, sexuality, energy storage, and expenditure. And I'll explain this in a second. But first, let's look at what happens in this HPA axis. So first, you have the hypothalamus. And it's going to, again, in response to stress or stimuli of some sort, it's going to produce corticotropin releasing hormone. And so corticotropin releasing hormone is going to cross over to the anterior pituitary. And in response to anterior pituitary, it's going to make adrenocorticotropic hormone. So adrenal, corticotropic, cortex. So it's going to go to the adrenal cortex. And in response to ACTH, the adrenal cortex is going to release cortisol. And The presence of cortisol then will serve as a negative feedback loop to tell the anterior pituitary and the hypothalamus to stop producing CRH and ACTH. How does this affect digestion, immune system, mood, and all of that? Basically, what happens is stress activates your sympathetic nervous system and the HPA axis. And, for example, digestion is a function of the parasympathetic nervous system. And so basically the way your body sees it is the threat, the stress, whatever is going on is more important than digestion, than fighting off an infection that, you know, may or may not kill you right away, right? So it's perceiving whatever is stressing the person as a bigger threat than anything else. It's a bigger threat than needing to digest food. It's a bigger threat than having to fight off an infection. You definitely don't need to be in a happy mood if you're under threat. And there's no time to make babies if you're under threat. And your energy storage and expenditure must be managed in a way so that it can be used to respond to that stress, to that threat that your body perceives that you're under. All right, so let's dive into the hypothalamus, the first part of this HPA axis. So the hypothalamus is located at the base of the brain, this little green area highlighted here. It is below the thalamus, which is why it's hypo, below thalamus. Its main function is to maintain homeostasis, and so I just like to think of it as it's like has little sensors in there to detect all kinds of things that's going on in your body. And so it receives a bunch of input from a lot of body systems to maintain a steady state. So it's constantly monitoring different hormone levels. It's also getting impulses from the brain, and it interprets all that and causes hormones to be released. So the hypothalamus can produce several releasing hormones. So we talked in HPA about corticotropin releasing hormone, but there are some other ones. So, for example, it can produce a thyrotropin releasing hormones. That would be for the thyroid system. Gonadotropin releasing hormone are going to be for the gonads, which are going to be your testes and ovaries. And there's also, for example, growth hormone releasing hormone. It can also produce inhibiting hormones too. So it could do growth hormone inhibiting hormone if it needs to inhibit growth. And it also contains neurons that can control the release of hormones from the anterior pituitary and the posterior, also from the posterior pituitary. So there is a neuronal network that connects the hypothalamus and the pituitary. The pituitary then is below the hypothalamus, and so it's highlighted here in orange, where the hypothalamus is like right here above it, and the thalamus there. So pituitary releases hormones in response to the hormones released from the hypothalamus or in response to nerve impulses from the hypothalamus. So the pituitary has two lobes, the anterior and the posterior pituitary, and the infundibulum is the little pituitary stalk, little thing that connects the pituitary to the hypothalamus. Okay, so they are really close to each other. So what produces what? The anterior pituitary produces the majority of it, and it produces these hormones, again, in response to, usually to releasing hormones from the hypothalamus. So it produces growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, follicle stimulating hormone, luteinizing hormone, and prolactin. So those are the main ones. Growth hormone affects growth. Thyroid hormone affects the thyroid. Adrenocorticotropic hormone does the adrenal gland with the cortical hormone, so the adrenal cortex. FSH and LH will work on the testes and the ovary. Prolactin is going to work on glandular breast tissue, but it also has a tie-in to stress response too. And in your posterior pituitary, the neural hypophysis, it's connected via a neuron network to the hypothalamus, and it causes a release of antidiuretic hormone, which is going to cause water reabsorption, and oxytocin, which can both drive lactation and uterine contraction during child labor. So this is a quick overview of everything. So again, posterior pituitary, it does not synthesize hormones, but it stores two hypothalamic hormones, so two hormones that are made by the hypothalamus, and then it will release it based on impulses from the hypothalamus. So again, antidiuretic hormone to maintain osmolality. So if your hypothalamus senses that your blood is too concentrated, there's a rise in osmolality. Blood is too concentrated, meaning it's dehydrated. Then it's the antidiuretic hormone will kick in and cause you to retain water to increase water volume in the blood. And so water balance is antidiuretic hormone, and then oxytocin again leads to milk secretion, stimulates uterine contractions during childbirth. It's also released during orgasm and stuff. It's a pleasure hormone. It's a bonding hormone, helps moms bond with babies, and so all of these. So these are the two that are posterior pituitary. And if you're trying to study all of them, I always say if you can at least remember which two are posterior pituitary, then you can figure out that pretty much the others are anterior. So again, anterior pituitary is the hormone synthesizing portion of the pituitary. It makes ACTH on a diurnal pattern, so a day-night, also kind of circadian. So that's adrenocorticotropic hormone. Growth hormone controls growth. Excess of growth hormone, you get gigantism. If there's a deficiency, you get dwarfism. Prolactin, of course, its main one is milk production. TSH is going to be affecting the thyroid, which then affects your metabolism and your body temperature. And then LH and FSH are your gonadotropins that affect your gonads. So your ovaries and testes, which are going to cause the production of gametes, eggs and sperm, and sex hormones like estrogen, progesterone, testosterone. The most common disorders in the pituitary are going to be a pituitary tumor, and then depending on where the tumor is located, you will have an increase of one of these guys that's secreted in the pituitary. So again, all of them put together with their effects. So we have the HPA axis here with cortisol release and adrenocorticotropic hormone, corticotropin releasing hormone. We have the thyroid axis here with TRH, TSH, and thyroid glands. We have the reproduction axis here with gonadotropin releasing hormones, LH, FSH, and then there are various effects on the ovaries and testes. And then we have growth hormone here. And dopamine with prolactin and lactation. So another matching exercise for the class. All right, so what are excess pituitary hormone disorders? So where too much of it is produced. So we have the syndrome of inappropriate antidiuretic hormone secretion, obviously affecting the posterior pituitary, and too much antidiuretic hormone is produced. So what does ADH do? Makes you retain water. If you have SIADH, then you're going to retain way too much water. And so it will have, because ADH just acts on water and does not act on sodium, you will see hyponatremia because it will be diluted out by all this water that's being reclaimed by antidiuretic hormone. Another one would be acromegaly. So this is excess growth hormone and insulin-like growth factor 1 after growth is completed, after the growth plate has closed. And so you get adults with longer limbs, and it also causes like their nose and their ears and stuff to continue growing. And so they won't get taller. So it's not, if you have excess growth hormone during growth, then there's gigantism. But if it's after growth, then it's going to be acromegaly. And then you can get hyperprolactinemia, so too much prolactin due to prolactinomas. And then in that case, with a male or female, like the breast can be producing milk even though there's no baby. And there's also, you can also see excess of adrenocorticotropic hormone, luteinizing hormone, follicle stimulating hormone, and TSH. So those would just be, there are different disorders that can cause these to be produced in excess. The deficit disorders So diabetes insipidus would be an antithyroid hormone deficiency. So you do not have, the patient there lacks the ability to reclaim water. And so they often have polyuria and polydipsia. They're very thirsty. And because of the polyuria and polydipsia, that's why it was named diabetes. This is different from the sugar diabetes. So this is the water diabetes, basically. But they were named by their signs and symptoms by the Greeks. And the word diabetes in Greek basically means siphon, so meaning drinking a lot and peeing a lot, and they're both signs and symptoms of both diabetes diseases, whether it's diabetes mellitus, which is sugar diabetes, or diabetes insipidus. So the serum and urine osmolalities and the urine specific gravity are going to be performed, and you would expect to see low specific gravity with a low urine osmolality. That would be the hallmark of the disease. And then, of course, a higher serum osmolality, because what it is you get a lot of very dilute urine, but the blood is dehydrated, but you can't produce an antidiuretic hormone. You can also measure antidiuretic hormone levels to help determine the type of diabetes insipidus. There is a neurogenic versus a nephrogenic, so whether it's a problem from the pituitary or a problem from the kidneys responding to antidiuretic hormone. My brother has diabetes insipidus, and he got it from a head injury. So head injuries can damage the pituitary and can cause this. You can also have hypopituitarism or pan-hypopituitarism. So again, meaning there's a lack of production of one or more of the pituitary hormones. Pan is lack of production of all of them. Again, head traumas can really do that, especially if the pituitary stalk is transected. Then it can cause all of it to not being produced. So with that, you would see ACTH, LH, FSH, and TSH deficiencies. You can also see growth hormone deficiencies if there's a deficit disorder here. So we're going to start with the adrenal glands. So we had introduced the HPA axis. So let's talk specifically of what the adrenal glands do. So the adrenal glands can be split into the adrenal cortex and the adrenal medulla. So the adrenal cortex is the outer portion here of the adrenal gland, and the adrenal medulla is the inside. The adrenal cortex produces the steroid hormones, the mineralocorticoids, and the glucocorticoids, and the adrenal androgens. It produces way more. It actually produces 30 plus hormones in this cortex. The cortex has actually 3 layers: the glomerulosa, fasciculata, and reticularis layers. Also G, F, and R layers, and each layer has cells that produce specific hormones. And then your adrenal medulla can produce estrogen in the form of estrone and epinephrine and norepinephrine. So that would be the center portion here. Now, again, if you look at, you have the cortex and the medulla. So the cortex is the outer portion, and then you have its 3 zones. So the zona reticularis, or R zone, produces all your androgens. The zona fasciculata, or the F zone, produces all your glucocorticoids, so like your cortisol, etc. And the zona glomerulosa produces your mineralocorticoids, so your aldosterone, things that affect the balance of sodium and water and other minerals. And then the medulla produces your catecholamines, which are your epinephrine, norepinephrine, and other hormones. Which section of the adrenal gland is wired to the nervous system? Do you know? Is it the cortex or the medulla? If you think about what hormones, you might understand, or you may know which one it is. And so just to give you, it's wired to the sympathetic nervous system. It would cause you to release stress hormones that are also known as adrenaline and noradrenaline. So that should give you a clue as to if it's cortex or the medulla. Okay, so let's start the adrenal cortex hormones. So aldosterone is the main mineralocorticoid one. It maintains extracellular fluid volume, and it regulates potassium metabolism. So aldosterone goes to act on the kidneys and it causes water to move from the urine back into the blood. But the way it does that is that actually it moves sodium. So it moves sodium from the urine into the blood, and water follows it. In exchange for moving the sodium from the urine into the blood, it will dump a potassium from the blood into the urine. And so it affects potassium and sodium balance and fluid volume. Cortisol regulates your metabolism of carbohydrates, proteins, and lipids. It's your main stress hormone, but it's also a main hormone that gives you energy in the morning. It is subject to diurnal variations. It is really on a circadian, on a 24-hour rhythm pattern. And so it is increased in daylight. It is increased in the morning, but you can see this circadian 24-hour pattern. It is lower at night, and then as you sleep, you restore your cortisol. Your cortisol levels go up, and then they give you energy. That's where you have the highest energy level in the morning when you first get up. And then throughout the day, here around noon, it starts dropping, and then you get tired because the more it drops, the lower your energy levels are, and then continues to finish dropping at night, and then it climbs back up. So, and then the androgens that are produced by the adrenal cortex are going to be DHEAS and DHEA. So let's look a little bit at the biochemistry cascade of all of this. So it's really important to understand what's going on here. So all of these hormones have the same precursor, which is cholesterol. Okay, so cholesterol is needed, which is why your body has the ability to make cholesterol as needed, because it's a building block to all these important hormones. Okay, so from cholesterol is made into pregnenolone. And then from there, your body needs to decide, or the body needs to decide, which direction does it need to go with this pregnenolone. Okay, so do we make 17-OH pregnenolone and then DHEA, androstenedione, and testosterone? Can we make that? Or are we going to go down 17-OH pregnenolone and make cortisol or cortisone? Okay, so stress. Or are we going to go down and make some progesterone for female, or corticosterone and aldosterone? Okay, and so, and you know, there are some limits to all this. So, for example, what you can have, so if a male is really stressed and they're making a lot of cortisol, so we're shoving this pathway here, we're favoring this pathway here, it will shut down this pathway. And so they can have, these males could have lower levels of testosterone, for example. Okay, and then this diagram is the response to aldosterone. So when aldosterone is present and it acts over here, it can stimulate. The stimuli for aldosterone is going to be decreased renal blood flow, nitric oxides from the macula densa, diuretics, epinephrine, norepinephrine, erect posture being early in the day, and input from the sympathetic nervous system. Things that inhibit aldosterone are going to be adenosine from the macula densa, angiotensin II, adrenaline blocking agents, aldosterone itself, recumbent posture later part of the day. And so the yellow part here is urine. This is the glomeruli here. This is part of the tubule, and then what's red is blood. Okay, so we have this interface here between urine and blood, where the juxtaglomerular cells in the macula densa are sensing the composition of the urine and the blood and what might need to be moved here or there. So generally speaking, what happens is if there is aldosterone is released, there's going to be, so you have increased aldosterone levels lead to increased sodium and water reabsorption by the nephron collecting duct, which increases the blood volume, okay? And aldosterone levels are going to be increased due to the presence of angiotensin. Angiotensin comes from angiotensinogen, converting to angiotensin 1 and angiotensin 2, and those will be released in response to renin, which will be produced by these juxtaglomerular cells. Again, stimuli here, inhibitors here for that release of the renin. Okay, so if renin is secreted, angiotensin is made, and aldosterone levels will be increased. And things that can drive the increased aldosterone levels are going to be hyponatremia, so sensing that there's not enough sodium in the blood, so let's move some sodium from the urine back into the blood. Hyperkalemia, there's too much too much potassium in the blood, so again, aldosterone can cause the body to put the sodium into the blood from the urine and the potassium from the blood back into the urine. And so it can cause dumping of potassium, basically. And then ACTH levels also, so stress levels will increase aldosterone levels and cause water retention, increase sodium, etc. So your adrenal medulla hormones, again, are your catecholamines, which are epinephrine and norepinephrine. They are released by nervous system stimulation. So that was the answer to the question, which one is wired into the nervous system, and it responds to sympathetic nervous system stimulation, which is sympathetic nervous system is your stress response, but it's your activity response. You're doing things. These guys have a 2-minute half-life, and they're part of the fight or flight response. Biochemically, they're made from phenylalanine, which is made into tyrosine. Tyrosine is made into DOPA, which is made into dopamine, and then dopamine is made into norepinephrine, which is then also converted to epinephrine. So these three right here are important hormones. Dopamine, after it's had its effect, is broken down as homovanillic acid. Norepinephrine and epinephrine are also broken down. So norepinephrine is going to be broken down into normetanephrine, and epinephrine is going to be broken down into metanephrines. And so these are usually called your metanephrines, and these are broken down into vanillomandelic acid. And so one test that can be done in the lab is a 24-hour urine for homovanillic acid and vanillomandelic acid, to see if there's an overproduction of epinephrine and norepinephrine. It's really hard to catch it in the blood because it only has like a 1 to 2 minute half-life. So it's not really doable to do blood draws for dopamine, norepinephrine, and epinephrine. It's way better to see to collect a 24-hour urine and see what's happening over a 24-hour period. And if you have increase in the breakdown products of these three, then you can at least surmise if it's going to be the epinephrine, norepinephrine, or the dopamine that's been increased, or all three. Okay, so let's go a little bit into the stress response, since the adrenals are very much involved in that. And so we're going to follow 2 pathways. We're going to look at the sympathetic nervous system pathway and then what happens in the pituitary. So when a stressor is perceived by the central nervous system, so it could be a threat to the body in somehow. And the crazy thing about as human is the stressor could be a direct threat, so some like being attacked, but it can also be a perceived threat, so something that's going on in the mind with thinking, thoughts, scenarios and things that are going on in the mind and causing stress. Okay, so it doesn't have to actually be real, it can just be perceived for the body to respond in that way. So the central nervous system will signal to the hypothalamus to release corticotropin releasing hormone, which is the stress hormone, one of the stress hormones. So start that stress hormone cascade. It will also, that in conjunction with the stressor itself, the central nervous system will signal the sympathetic nervous system to activate. So let's follow the sympathetic nervous system. All right, so the sympathetic nervous system is going to go to the adrenal medulla, and it's going to activate the release of epinephrine and norepinephrine. So norepinephrine can become neuropeptide Y, cause vasoconstriction, and then vascular growth factor and genic factor. So it can grow more blood vessels, but they're going to be constricted. Okay, it will increase blood pressure. It will increase sweat gland action, so the person will sweat in the armpits and palms, so stress sweat. It will increase pupil dilations. It will increase the arterial smooth muscle contraction. So again, it's a vasoconstriction going on, and it's going to give the person goosebumps, so make your hair stand on end. So that's all of those are effects of norepinephrine. Okay. Then epinephrine is going to give the person bronchodilation, so we can get good air, open up those lungs, right? Because air, oxygen means that you can make more ATP, which is more energy, right? You're going to see an increased force and rate of cardiac contractions, so the heart is beating faster and harder, which increases cardiac output, which increases oxygen delivery to the cells. We're going to see increased lipolysis, and we're going to talk about that where it happens, but the idea is the fat's going to be broken down, and so they all show, the fats, circulating fatty acids are showing up in the bloodstream. In the pancreas, insulin production will be decreased and glucagon production will be increased. So because there's less insulin, there's going to be less glucose uptake in the skeletal muscles and adipose, which then will increase the blood glucose to be used, for example, by the heart and other areas of the body. And glucagon is going to be increased, which causes gluconeogenesis, which also increases blood glucose. So this is where also stress, especially chronic stress, can increase a blood glucose level. And then in the liver, there's decreased glycogen synthesis because of the decreased insulin. So that's tied into there. It makes sense. And increased glycogenolysis, breaking down the glycogen to increase the blood sugar, right? And increase gluconeogenesis because that's where it happens in the liver. So all of these things are going on just by the activation of the sympathetic nervous system and the release of epinephrine and norepinephrine. Now, on the pituitary end, corticotropin releasing hormone is going to also trigger that release of antidiuretic hormone and water retention. Water retention then also is going to drive that blood pressure up some more. And then in the anterior pituitary, then corticotropin releasing hormone is going to go do its job and release adenocorticotropic hormone, which is going to go to the adrenal cortex and cause a release of cortisol. Cortisol will have multiple effects. So it's going to increase blood pressure and cardiac outputs. So it's, again, just kind of some of these same effects as the sympathetic nervous system, although cortisol tends to be more longer-lived and epinephrine and norepinephrine tend to be more shorter-lived. It's going to increase lipolysis in the extremities. So there would be fat loss in the limbs, so the limbs get skinny, but it's going to increase lipogenesis or fat deposit to the face and trunk. So it's kind of like there's a shifting of the fat mass, and they get a fatter face and lots of fat around the abdomen, but skinny arms and legs. There's also going to be atrophy of the lymphoid tissues, meaning so it affects the immune system. And these effects can be both anti-inflammatory. So cortisol or cortisone is an anti-inflammatory molecule. But in some instances, it can also be pro-inflammatory, depending on the cytokines that are around. And it can do immunosuppression, so suppress the immune system, or enhance humoral immunity, which also could mean the production of autoantibodies in autoimmune diseases. It also increases the blood levels of amino acids, and is going to decrease luteinizing hormones and the sex hormones, estradiol, testosterone, because, again, if the body is stressed and under threat, this is not the time to be making babies, so shut down the production of those hormones. So let's look at this case. So this is really a good illustration of what cortisol does. And so you can see the change in this person's face from normal before to after she has Cushing's, and you can see the roundness of the face increases, just fat deposit around the face. And so she's 45. She recently went to health fair, and she has high blood pressure, moderate hypertension. She has central obesity, so lots of fat around the abdomen. She has thin limbs and a round, ruddy face with some redness to it, right? You can see that redness increase versus what she was before. She was not taking any medication, so her blood pressure was elevated at 160/100. Her fasting glucose was elevated at 120 milligrams per DL, so not quite diabetic, but getting pretty close. 8 a.m. and 4 p.m. cortisol levels were elevated at 32 and 30. So if you remember, we're talking about cortisol is higher in the morning, lower in the evening. Where's this lowering? It's not there. So she has too much cortisol. It's high all the time. So what would be her probable diagnosis? You should be able to pick it up because I've already mentioned it and it's on the photo. So which one of these is it going to be? Okay, so let's talk about these disorders. So what she had was Cushing syndrome. So there are several. There's hyperaldosteronism. So we already saw kind of what aldosterone does. So when hyperaldosteronism, there's increased levels of aldosterone in the blood, which basically ultimately is going to increase the blood pressure because it's going to increase fluid retention and salt retention. Cushing syndrome is too much cortisol. So this one's too much aldosterone, this one's too much cortisol. And again, it's basically like a stress response that's always on. It's going to have all the effects that we talked about in the stress response, which is why the patient had a round face, central abdominal obesity, but thin limbs. Then there is congenital adrenal hyperplasia, and this one there's a decreased production. It's congenital, but there's decreased production in cortisol and aldosterone and increased production in androgens. Addison's disease, there's decreased production also in cortisol and aldosterone, but this is an autoimmune disease. It can also be called primary adrenal insufficiency. Now, in the adrenal medulla, the two main ones are going to be pheochromocytoma, which increases epinephrine and norepinephrine. It would be detectable again by its breakdown products. And neuroblastomas can be other places, but they can often be found in the adrenal medulla, and it's a cancer, it's a tumor of the sympathetic nervous system. So again, hyperaldosteronism, too much aldosterone, you get hypertension because of an increased plasma volume and a suppressed renin-angiotensin system. Too much aldosterone means you're retaining too much sodium, which is again give you high sodium levels in the blood and hypertension. They're going to excrete potassium because that's what aldosterone does. It trades sodium for potassium. So we're keeping all the sodium, dumping all the potassium, and keeping all the water. And so therefore they'll have hypokalemia, and that will be evidenced by weakness, paralysis, metabolic alkalosis, and polyuria. Again, this is an illustration of Cushing's with excess cortisol. So what do you see? Acne, the ruddiness of the face with the moon face, the increased weight around the face, thinning of the hair, increased body and facial hair, truncal weight gain with purple striae from that weight gain that's increased around the trunk, a pendulous or like hanging abdomen, proximal muscle wasting, so arms and legs are getting skinny, and thin skin with loss of subcutaneous tissues and slow wound healing, hyperpigmentation with a supraclavicular fat pad here and a buffalo hump. So this is a pretty typical Cushing look, and so this is all from excess cortisol. Okay, so moving away from cortisol, adrenal axis, and all of that into the pancreas. The pancreas does have its own chapter, its own lesson, and so and we've discussed pancreas for exocrine and digestion, but pancreas also has an endocrine function. So the hormones that are produced by the pancreas are insulin, glucagon, somatostatin, gastrin, and serotonin. Insulin drives the formation of glucose to glycogen for storage and the use of glucose in the cells. Glucagon does the opposite of insulin, so it drives glycogen to release glucose during fasting. Somatostatin is also stimulated by glucagon. It blocks digestion. Gastrin is produced by the stomach and helps the release of gastric acid in initiating all the digestive processes in which the pancreas participates. And then serotonin contracts smooth muscles of the GI tract and helps move food along the GI tract. The pineal gland is also up in the brain. It produces melatonin. Melatonin is responsible for your circadian rhythm, your own personal circadian rhythm, meaning what time you get up in the morning, what time you go to sleep at night. So your wake and sleep schedule. It also regulates FSH and LH, which drive reproduction. So they're tied into reproduction. It regulates body temperature, and it is also an antioxidant. So interestingly, so melatonin is made from serotonin, and serotonin is made from 5-HTP, which is made from tryptophan. Tryptophan is amino acid that is found in turkey, for example. So there's another reason, for example, why turkey can make you sleepy, because it would increase your melatonin levels. But generally speaking, your melatonin levels rise at night when it's time for you to go to bed, and that's why it makes you sleepy. And getting good sleep then maintains, one, a good circadian rhythm, but also good reproductive function. Your thymus. So your thymus is here over your sternum, if you will. It is part of your immune system. It's part of the lymphatic system too. It produces thymopoietin and thymosin. Thymopoietin, this job is the differentiation and the maturation of your lymphoid stem cells into T cells. So in your lymphocytes, you have T cells and B cells. Your lymphocytes are white cells in your blood. Your T cells do cell-to-cell immunity. So they find cancer cells and viral infected cells, etc., and destroy them. And your B cells create antibodies. So this is just the T cell part of it, of immunity, and your thymosin hormone does the late T cell maturation before it's released into the blood. And so the reproductive system hormones, so there's going to be later on a chapter just on the reproductive system, but the ovaries produce estrogen. Estrogen, there are actually several estrogens. Estradiol is the predominant one that's produced by female that are in their reproductive cycle. But they you also produce, this is also known as E2, estradiol, D-O for 2. There's estrone, which is E1. Estrone is the one that's still present after postmenopause, and it's an estrogen that can be produced by fat cells, by adipocytes, and also by the adrenal gland. And the third one is estriol, or E3, and that estrogen is produced by pregnant women. So estrogens in ovaries help facilitate the maturation of the follicle so that egg can be released. It's higher in the beginning cycle of the menstrual cycle. Progesterone is higher at the other half of the menstrual cycle. The job of progesterone is growing and maintaining the uterine lining, but also maintaining the early pregnancy, allowing for the fertilized egg to implant and all of that. So progesterone is important in that. The ovaries can also produce small levels of your androgens, so the testosterones and other androgens. And then the males make testosterone. Males are always so much more simpler than females. All right, so quick little poll. Which one of these hormones can help build the uterine lining and maintain early pregnancy? I just said, if you weren't sure, you can just rewind. The thyroid gland. So the thyroid is really important. So the follicular cells of the thyroid secrete thyroid hormones. Your thyroid hormones are T3 and T4, and they're made from tyrosine. Now, there is a difference between the two. T3 is the active thyroid hormone, and T4 is its precursor, so it's in inactive form. And both float in the body, although you have a lot more T4. And so T3 is responsible for the metabolic changes for the action, and it actually goes into the cell and acts in the nucleus to turn on different processes. It is on a feedback mechanism with thyroid stimulating hormone and the pituitary gland, and it's under the control, of course, of the Hypothalamic-pituitary-Thyroid Axis. Your metabolically active forms of T3 and T4 are the ones that are free floating, so it's free T3 and free T4. Total T3 and total T4 are T3 and T4 that are bound to the carrier proteins. The main job of these thyroid hormones is to regulate energy metabolism, so they kind of help dictate basically how well you use energy and how much ATP and stuff you can produce on the energy that arrives into the cell. So it sets your basal metabolic rate. And the parafollicular cells, so the cells that are around the follicular cells, secrete calcitonin, and calcitonin is involved in bone and calcium metabolism, and so we'll have a whole chapter on that. So again, as a review, TRH is secreted from the hypothalamus to the pituitary. Pituitary in response secretes TSH. TSH goes through the blood to the thyroid, tells it to release T3 and T4. T3 and T4 go and have the metabolic effect and have a negative feedback back to the hypothalamus. So the thyroid gland disorders are hypothyroidism and hypothyroidism. You can have a primary, secondary, or tertiary cause of both. So if the cause is primary, the defect is, the problem is in the thyroid gland itself. Whether it's not making enough or making too much, is the thyroid gland that's the problem is in the thyroid gland. If it's secondary, the problem is going to be in the hypothalamus or the pituitary. And if it's tertiary, it's hypothalamus or pituitary, but due to a tumor. This is the pattern here, whether it's, with hyper and hypo, that is the most seen, and it's going to be a primary. So primary hyperthyroidism, what you will see is going to be high thyroid hormones. That's why it's hyperthyroidism, but low TSH. Why low TSH? Because the pituitary is detecting that there's an excess of thyroid hormone, so it's completely shut down the production of TSH, because we do not need to stimulate the thyroid hormone to make any more than what is already being made. The most common cause of primary hyperthyroidism is going to be Graves' disease, which is an autoimmune disease. Now, I do want to mention here that if you see secondary hyperthyroidism, so the cause is in the pituitary, what's going to happen is the pituitary is making too much TSH, and because there's too much TSH, there's too much thyroid hormone. So the pattern you would see with secondary hyperthyroidism is going to be high thyroid hormones, but high TSH. Okay, so that is, it's possible to see. It's just not seen as much, but it is possible to see secondary hyperthyroidism. Now, same in hypothyroidism, majority cases are going to be primary. You're going to see decreased thyroid hormone, which is why it's hypothyroidism, and an increased TSH. So the pituitary is sensing that there's not enough thyroid hormone, so it's going to keep releasing thyroid stimulating hormone to try to stimulate the thyroid to make more. Okay. The most common primary cause of primary hypothyroidism is going to be Hashimoto's. It is also an autoimmune disease. But this one, you have low thyroid hormones. And then the other one, the other risk with hypothyroidism is what we call congenital hypothyroidism. So these are infants that are born not making enough thyroid hormones, and it can be very dangerous to their brain development and develop what they call cretinism, which is basically a really pronounced form of mental retardation. So this has to be screened for and detected early on, so it can be prevented with the administration of thyroid hormones and things, so that the baby can develop, his brain can develop normally. Just like there is for hyperthyroidism, you can have secondary hypothyroidism. So in secondary hypothyroidism, what would happen is the anterior pituitary is not making any TSH at all. And because there's no TSH, or not hardly any TSH, there's not enough thyroid hormone. So in secondary hypothyroidism, what you would see would be decreased thyroid hormones and decreased TSH. Okay, so again, what would be the difference between a primary and a secondary hyperthyroidism? I just kind of explained it already, but if you can remember that. And which of these do you think matches hypothyroidism? So if you need to, you can pause and look at it, but only one of these would match hypothyroidism, and I will tell you it'll be the most common, the primary hypothyroidism. So our last stop in this journey is going to be the parathyroid glands. So they produce parathyroid hormone, and parathyroid hormone regulates calcium through the kidneys and the bones. The main job of parathyroid hormone in conjunction with calcitonin is to maintain the blood calcium level at a set point. And so if that calcium level drops, the parathyroid hormone is going to be produced by the parathyroid glands, and the parathyroid glands are not tied at all to the hypothalamus pituitary to act on their own. They on their own can sense the calcium level in the blood, and there's a feedback mechanism there for these 4 little parathyroid glands to produce parathyroid hormone in response to low calcium levels. So what happens is they sense a decrease in serum calcium that causes parathyroid hormone to be secreted. It's going to act on the kidneys, or travel over to the kidneys. In the kidneys, it's going to stimulate basically an increase in vitamin D. And it's going to also act on the distal nephron. It's going to cause calcium to be reabsorbed and phosphate to be secreted. Or at least not reabsorbed as much. So phosphate levels will go down, calcium levels will go up, and that will cause them to basically put calcium from the urine back into the blood. So that will increase the serum calcium and decrease the serum phosphate. These guys usually move in opposite directions. Vitamin D is going to go act on the gut and cause an increased reabsorption of calcium in the intestines. Parathyroid can also act on the bone, and basically the net effect of this activation in the bone is it's going to cause the bone to break down and release calcium that's stored in the bone. It will weaken the bones, but it will raise the blood calcium level. And so this is important because we need adequate calcium in the blood for the heart to beat properly. And so the body's main goal is to maintain serum calcium to the right level. So the parathyroid gland can be hyper or hypoparathyroidism. So again, the disorders in hyperparathyroidism can be primary, secondary, or tertiary. Primary hyperparathyroidism, you'll see high calcium and high PTH levels. It's because the parathyroid hormones are being activated. Secondary is actually seen in chronic renal disease. So this is where it's slightly different from the HPA stuff and the axis things. And tertiary is going to be kind of like primary, but the reason is a tumor of some sort. And then hypoparathyroidism, so not being able to produce enough, is usually due to injury or trauma to the parathyroid glands, and you see decreased parathyroid hormone levels in that case. That is the end of the endocrine system. That was a long chapter. So thank you for your attention. If you have any questions, please either email them to me if you're in class, or drop them here. If you're on YouTube, feel free to drop them in the comments below. So thank you.